Okay, and we are live. Good morning, or good afternoon, I guess. Sorry, everyone. Thank you all for joining our session this morning, our first session of week 5. Today, we have the pleasure of hosting Dr. Joanna Schirtz, a pediatric gastroenterologist. As always, please remember that the Google form where we can verify your attendance will be posted in the comments at the end of today's session. And with that being said, you can start presenting whenever you're ready. Sure.
All right. Well, good afternoon, everyone. Thank you, Web Shadowers, for hosting today and for all of y'all joining live. My name is Dr. Joanna Schirtz. I'm a pediatric gastroenterologist. And today we'll talk about a few common complaints that I see and treat in clinic. So I have no financial disclosures to share. These cases are examples. No real patient information is used. This is for discussion and education only, and nothing I discuss during this presentation is representation of my employer. So I really wanted to congratulate everyone that is committed to this virtual shadowing. I know that this can be really difficult and a really unsteady time, especially when you're trying to figure out classes and exams and applications, and you really can't do this in person. But I do want you to know that we as a medical system are also doing all of this for the first time and trying to figure it out. So really don't be so hard on yourselves. Do what you can. You're already one step ahead of the game by joining these sessions and exploring medical options that are available to you. So this is a little bit about myself. I was born in Poland. I traveled across the pond to the US for the first time when I was 1.5 years old. And then I went back to Poland and I did this back and forth thing for half a year at a time until high school. And so I went to Northwestern University for undergrad. I studied biology and anthropology. And I also played a Division I sport. So with that, I had a lot of things going on, but actually I didn't really feel comfortable to take my MCAT until my senior year. And so I took it my senior year, I got my score back, I did fine. And I had an option to either wait until the next year to apply or take a gap year since I missed the deadlines for the US schools. And I was able to find a program in Poland. I had 1 month before deadlines closed, and I really didn't know what I wanted to do for the gap year. So kind of after assessing all of the options with my parents, I decided to apply. I got in. It was an awesome experience. I was close to family. I saved a lot of money. I was able to get credentials and did well on exams, and came back to the States for residency. I did pediatric residency at the University of Tennessee in Chattanooga and really fell in love with the South. So I went to fellowship at Emory University in Atlanta, and now I'm practicing in Georgia, and we really love it here. So we hope to stay for a long time. So here are some pre-med tips that I thought from my experiences that I could share with y'all. So one thing is to pick your major based on what you're interested in. I know a lot of you are in college and are going through this right now. I started as a biology major and then midway through fell in love with anthropology. And so I completed both. And in hindsight, you can really do any major and take the required classes and be just fine. And so research the programs you're interested in. And make sure you know about the deadlines early. Make sure you schedule your MCAT appropriately and give yourself enough time to study. And I'm sure y'all have had many exams so far, but what really worked for me was planning. So I have an old school planner. I write down everything. I write down every appointment for the week. My presentations, my patient procedures, my meetings. I write down my to-dos and then I check everything off as I do it. And I've found that this is really satisfying and it's kind of kept me on track. And then lastly, I wanted to mention some volunteer opportunities that you can look into. I think it's really important to be creative and to help others during this time. So in high school, I participated in Handwritten Hearts. We wrote letters to patients in nursing homes and physical rehab facilities, almost like a pen pal thing. Um, Another great opportunity, if COVID permits, is helping healthcare workers with childcare. So this has been a struggle for a lot of essential workers. And if you have time and it's safe, then that's something to look into. And then lastly, tutoring. So it can be done virtually in many different subjects. So those are just some of the examples I wanted to share with y'all when putting together this presentation. All right, so why pediatrics? So I've always really been fascinated with childhood development. I love kids. I have a younger sister who is 6 years younger than me, and I really helped raise her. I did pediatric research in medical school and volunteered at the Children's Hospital. And so I was genuinely really happy working with kids. So I always knew I wanted to go into pediatrics. And then really starting medical school, it wasn't, after medical school, wasn't until residency that I experienced everything that GI had to offer. So I found myself in rotations like the NICU, and I was mostly interested in the feedings and diet changes and tube feedings in babies and formula and milk changes. So I found this common interest, and that was really GI in all of my rotations. And then what was really interesting is that GI is able to combine patient continuity with procedural skills. So I really liked the emergency room. I really liked ICU for that hands-on experience, but I couldn't really get away from the fact that I would not be able to follow a patient, follow their diagnoses, build a relationship with the family for a long-term way. And so we're really able to do that in pediatric GI. We do a lot of procedures. We are not surgeons. I want to make sure everyone knows that. We do treat things like bleeding. We do foreign body removals. We perform endoscopies, colonoscopies. We examine and treat the upper and lower GI tracts. We can do ERCPs to look at problems with the pancreas, liver biopsies, and really so much more. And what's really cool about GI is that you can really become an expert in a subfield. So that really interests you. So for example, one of my passions is inflammatory bowel disease, specifically Crohn's disease and ulcerative colitis. And so I care for a lot of those patients. I have a subspecialty clinic in this. I do a lot of quality improvement within IBD, and I do a lot of clinical research now with that too. So that's a GI in a little nutshell. Before we jump into the cases, we definitely need to understand some basic anatomy. And so in GI, we treat everything from the mouth down to the esophagus. Can you all see my pointer here? So down the esophagus and then into the stomach. Then that enters the first part of the small intestine, the duodenum. The gallbladder, pancreas, liver all have tracts that feed into that. And then you go through the rest of the small intestine, and then you go up the colon and then down the rectum into the anus. So let's jump into a few common chief complaints that we see in clinic. So we see anything from constipation, reflux, weight loss or weight gain, failure to thrive, which is trouble gaining weight, abdominal pain, diarrhea, celiac disease, inflammatory bowel disease, GI bleeding, dysphagia, which is trouble swallowing, eosinophilic esophagitis, which is an allergy that can occur in the esophagus, hepatitis, which is a problem in the liver, jaundice, pancreatitis, inflammation in the pancreas, intestinal ulcers, and foreign fatties. All right, so we'll go through 3 cases, and we'll pretend, like we're in clinic. So we'll spend about 15 minutes on each. So this is our first patient, KM. He is a 3-month-old term male that is coming in with his mom, and he was sent in for the chief complaint of reflux. And so we took a little bit deeper and find out from mom that he was born at term at 39 weeks. So term pregnancies are between 37 and 40 weeks. He was delivered naturally. He didn't have any complications. And so initially mom was breastfeeding him for 2 weeks, and then she transitioned to a standard infant formula. She noticed that he had some increased spit ups and vomiting with most of his feeds. They went to the pediatrician, and the pediatrician switched his formula to a little bit more broken down formula. We won't really go into this as much, but it can be easier to digest. But the baby continued to have spit ups and vomiting, and then he was again transitioned to a different formula that was a little bit more broken down. So with that transition, the spit ups did improve, but they still persisted. And with the mom and the pediatrician, they decided to come see the GI doctor for further evaluation and management. So we need to ask some more questions. The first thing is, what do the feedings look like? So mom mentioned that he gets about 6 to 8 ounces per bottle. So just for reference, there's 12 ounces in a Diet Coke can. He gets about 7 or 8 bottles per day, and mom's mixing the formula appropriately like it's labeled on the can. And the baby is spitting up pretty much with every feed, maybe not as much of the volume like prior to the formula changes, but it's still present. The baby doesn't have any blood in his spit up. The baby is happy, not irritable. There is no choking or gagging or trouble with finishing the bottle. And the baby has plenty of wet diapers. So that's one thing we want to make sure of, is if the baby's having vomiting or spit ups, we want to make sure that they are staying hydrated. So mom tells us that the baby has plenty of wet diapers throughout the day, is stooling 1 to 2 soft stools per day. And then on further questioning, she does mention that we don't have any fevers. There's no cough or congestion, no diarrhea. There's no rashing, bruising, abdominal distension, or any vomiting during the night. So next up is the physical exam. And the baby appears well nourished, no acute distress. The baby's head is normal cephalic, meaning normal shape. The soft spot is open, nice and flat. The nose and the mouth are clear. There are no masses, no lymph nodes felt on his neck. When we listen to him, he is clear. His lungs are clear. There's no wheezing. There are no crackles. His heart sounds regular. And then we feel his belly. It's nice and soft, not distended or protruding. There doesn't appear to be bothering him when we're examining his belly. There are no masses that we feel, and the bowel sounds are normal. And so we look at his rectum. It looks normal. There's normal tone and location. We don't see any tags or tears. He has normal development on Tanner scales, and his skin is clear. He doesn't have any rashes, and he's alert with a normal tone, and he's very appropriate for age. And so these are his growth charts. We use the WHO growth charts for boys and girls under 2 years old. So his weight is 20 pounds, 9.1 kilograms, and that's on the top. And you can see that's above the 99th percentile. And his length is 26 inches. So that's also at the 99th percentile, that's on the bottom. So he's a big baby, but very proportionate. And so what do we do next, right? So this is where we really have to realize that parenting is tough. This is a first-time mom that needs to be heard. She wants someone to listen, and it's our job to make sure that there are no red flags and that we reassure mom and try to help her moving forward. And so we need to know what is reflux, because we see a lot of these babies as general pediatricians and then as GI physicians too. So reflux is the passage of gastric contents back into the esophagus with or without regurgitation, which means actual visible vomit or spit up that comes back up and out of the mouth. And so it's a physiological phenomenon, meaning that it is normal and it's occurring in all ages and allows for depressurization of the stomach. And so we all have reflux. And so why it actually happens is a little bit more complex, but there are three main reasons to think about when it comes to reflux. So first, the esophagus. So it's the tube that connects the mouth to the stomach. And it has immature coordination and motility in little infants. It doesn't move food down always appropriately. And it's fairly short, right? And so they are little. You don't have that natural protection that we have as adults. And then second, the stomach. So the stomach is small. If you think about the size, I often see infants that are fed or overfed more than the stomach can handle. So maybe this little one taking 8 ounces and 8 bottles a day is a little bit too much for him. And then the way the esophagus is connected to the stomach, there is this almost like protective angle right here that develops with age. So with age, it creates more of an angle and it almost acts like a block from the food to come back up. And that's really not yet fully developed in babies. And finally, the babies literally are fed around the clock, sometimes every 1 to 2 hours when they want to feed on demand. And you know what? They're often laying down. And so I always tell this to parents. Imagine if you or I were laying down when we were eating all the time. That would be probably very uncomfortable. And that's why milk can come back up, and oftentimes it does. And so babies are expected to eat and even stool laying down. And really, that's not fair, right? None of us do that. So it can be tough sometimes to have everything coordinated for these little ones. And so what is normal and who is at risk? So 100% of babies reflux. So we don't always see that, right? Because it doesn't always have to come out of the mouth, but about 50% of the time, babies have visible reflux. And the peak is around 3 to 4 months. So this is where our patient is right now at 3 months old. And the great thing is that 80% of all reflux usually resolves on its own between 12 and 18 months. Even if we did nothing, this would resolve on its own. And there was a study that showed that healthy infants can reflux anywhere between 30 and 100 times a day. So the norm is really high. And if you think about many of those refluxes we don't see, and they don't always have to come out of the mouth. And so who is at risk? Babies with developmental or neurologic conditions, for example, cerebral palsy, they can be more at risk. Premature infants have higher rates of reflux. They need to coordinate sucking and swallowing and breathing all at the same time to have an efficient feed. And preemies just need more time to figure it out. So outside of the womb, especially if they're born before 35 weeks. And so when should we worry about reflux? So parents should definitely worry and see their pediatrician if their baby is spitting up to the point where they're concerned about weight loss. The color of the spit up is green or yellow, not like the milk that they ate. If there's any blood, if the baby refuses the bottles, if there's any difficulty breathing, if there's any choking or gagging with feeds, if there's a chronic cough. And of course, you have to go to get more urgent or ER referrals if there's any forceful vomiting followed by this desire to eat. Sometimes babies can have pyloric stenosis when this happens, and then any kinds of acute signs of dehydration. So when there's not enough wet diapers, when babies cry, they often have alligator tears, and if those aren't present, or if there's dry lips or dry mucous membranes, those are all reasons to go see urgent physicians. So what can we do for this mom? So we can reassure her and let her know that she's not alone. Remember that all babies can have reflux, right? And so she's in the peak of it. It's getting worse or not, but she's at the 3 to 4 month mark. And 80% of the time it'll resolve by 1 year old, by the time the baby's 1 year old. But that's a long ways from now. So what can we tell her? So we can offer some reflux precautions, which means holding the baby upright 20 to 30 minutes after feed. We don't like putting the baby in a car seat or a swing. That can sometimes build up pressure in their bellies and cause more spit ups. And then we also want her to burp the baby mid-feed. Sometimes if we wait until the end, the burp may look more forceful and more milk may come out. And so I wanted to share this with y'all. So as pediatric gastroenterologists, we are part of a committee called NASPGHAN, so North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. And this is a great resource for research, education, clinical resources, and guidelines about pediatric GI and topics and diseases. So what does NASPGHAN do? Well, it gets a lot of experts in a certain field together, and they review all special research proposals and research that's come out to make recommendations on certain topics. So for example, you can see here, there are topics like H. pylori, peanut allergies, liver disease, jaundice, hepatitis C, and so many more. And so these are all available online. Anyone can access these if you're interested. And then there are 2 great adult GI resources, the AGA, which is American Gastroenterological Association, and the ACG, American College of Gastroenterology. And so this provides guidelines for a lot of topics in adult GI. Also available for anyone to access. Okay, so this is our guideline for reflux from NASPGHAN. So we will go down the line. So we have the suspicion of reflux. We did not find any alarming signs in this baby. So next we should avoid overfeeding. So we can talk about the feeds and how much mom is giving. And then the next thing to try is to thicken their feeds. So that means adding a little bit of rice or oatmeal cereal into bottles and to thicken that liquid to help maybe keep some of that liquid down. And the baby's already on broken down formula that's better digested and is gaining weight beautifully. So again, we reassure that this will improve with time. We will make sure we follow up with the patient closely. So bring them back, every 4 to 6 weeks to see how they're doing. Parents knowing that they have closer appointments, that also helps them to know that we are monitoring the baby closely and we're following up. And so that's really, that really builds a good relationship between the patient and the provider. All right, so we'll move on to the second case. So this one will be a little bit shorter, but it'll be on a similar topic, just in a teenager. So we have a 17-year-old female, SK, who is coming with her parents for a chief complaint of heartburn. And so she's had a past medical history of an appendectomy. So her appendix was taken out when she was 8 years old. She's had eczema. And she recently went to Uganda for a mission trip with her parents. And during that mission trip, she developed chest pain and discomfort when eating fruit. And so she's never had these symptoms before. She went to her pediatrician, who appropriately told her to avoid the trigger foods, which in her case, she was thinking were fruit. And she could take an occasional Tums, which is a calcium carbonate that can help with some symptoms. And this helped, but it didn't fully recover or resolve symptoms. And so she was referred to see us in the GI clinic for further evaluation and management. And so we want to ask her some more pertinent questions. So first, are there any associated symptoms? So is there any abdominal pain? Is there any vomiting? Is there any diarrhea or constipation? We definitely want to ask about dysphagia. So is there any trouble swallowing? Does food feel like it's getting stuck at all? Is there any blood in her stool? Is she having any fevers, cough, congestion, runny nose, muscle or joint pain, any headaches? So the most common presenting symptoms for reflux in older kids is going to be heartburn, chest pain, abdominal pain, nausea, and vomiting. So we have to keep that in mind. And we dig a little bit deeper and we really see what she's eating to see if we could figure out any other potential triggers. So she tells us that she loves coffee, right? And so she has coffee every single day. She has a few cups of coffee a day. She eats fruit. Well, for breakfast, she's been trying to limit it, but she still has some fruit and yogurt. And then she actually works at Chick-fil-A. And so she has nuggets, fries, or a sandwich almost every day. She, for dinner, has pasta or spaghetti. Her parents like to make different meat and fish, vegetables, potatoes, and rice. She is not on any other medications other than the occasional Tums. And then the family history. So dad actually has GERD, or gastroesophageal reflux disease, that he was diagnosed with a few years back, and he has hypertension. And mom has IBS, so irritable bowel syndrome. And so for her physical exam, so she appears well. She is not in any acute distress. Her nose and her mouth are clear. Her lungs sound good. Her heart sounds good. Her abdomen is soft. It's non-distended. She does have some discomfort to deep palpation in the epigastric abdomen. So that's above your belly button. She has no organomegaly, so we don't feel any abnormally large liver or spleen, no masses, and her bowel sounds are normal. And so we didn't look at her rectum. Her skin is normal. Neurologically, she's also very appropriate, and her height and her weight are both in the 50th percentile, and her BMI is also in the 50th percentile. And so with this, we look at the next steps. So there are no alarm signs present. And so with that, the lifestyle and dietary education should be reviewed. So for many patients, especially older children who are developmentally normal, a really thorough clinical history and physical exam can be enough to diagnose reflux. She likely has some reflux that's causing her this discomfort in her chest when she eats the trigger foods. But what we have to remind her is that she might be eating other things that are common triggers that can worsen these symptoms. So for example, not just acidic fruits, like she's been, limiting, but things like ketchup and spaghetti, coffee and caffeine in general. Those are all dietary triggers. Chocolate and spicy foods, high fat foods. So her, working at a fast food place and eating at least one fatty food per day might be contributing to her symptoms. Alcohol and smoking is really something we discuss with adults. That's not common in pediatrics. I didn't mention this here because she has a very appropriate BMI and she's not overweight, but sometimes obesity can cause reflux symptoms to be worse. So at that point, we would talk about weight loss. And another thing she can try is avoiding to laying down for at least 2 hours after a meal. She can eat smaller, more frequent meals. And then one thing we can definitely do is try acid suppression medicine for 4 to 8 weeks. So we keep patients on this for a few weeks, and then after a month or two, we can attempt to wean off of the medicine. If there is an ulcer in the stomach or gastritis or irritation in the stomach, then this acid suppression medicine can definitely help cure that too. And then if the wean is not successful, then we might have to look with a scope called an EGD, where we go down the mouth and into the esophagus and into the stomach and that first part of the duodenum. And we can look, we can take pictures, we can take biopsies, so little bites of the inside mucosa, so the pathologist can look at specific cells. And so if that's needed, then that is definitely one thing we can offer her. But at this point, we'll trial the medicine for a few weeks. We'll see her back in clinic, and we'll kind of go from there. Okay, and so this is our last patient, JD. So JD is a 5-year-old, previously healthy female. So she's coming in with mom for the chief complaint of abdominal pain and trouble stooling. She has a past medical history. She was born term. She has been diagnosed with autism. She was 2 years old. And with that, she has some mild speech delay. She is able to tell mom if she has any belly aches. And mom has said that she's definitely noticed her belly pain resolve after she has a bowel movement. She's also able to point to her belly where it hurts, and she's pointing to this left lower abdomen to localize the pain. And so they went to see their pediatrician, who recommended some dietary changes, which can include drinking more water or having some juice, eating more fruits and vegetables. But mom admits that this was very difficult to do. The patient has a very narrow palate from what she's actually eating because of her underlying autism. And so a few additional questions that we have to ask. So we have to ask if the baby, when she was a baby, if she stooled on the first or second day of life. So mom tells us that she had this black tarry stool called meconium at day of life 1. This is important to ask. A baby's first stool, depending on the timing, can be important if we're trying to rule out something called Hirschsprung's disease. And after more details about her poop, she tells us that she stools maybe once or twice a week. The stools are fairly hard. They are Bristol 1. And so this is a really fancy stool chart that I love. This is the Bristol stool chart. It was developed in 1997, initially as a research tool to help patients or in research to talk about how stool changes to various treatments. And so it is type 1 through 7. Type 1 are hard balls, pellets, and then all the way to type 7, which is watery, loose diarrhea. And so we have these charts in clinic, all around the clinic. It's easy for kids and parents to point this out and to show me what their stools look like. I recently made a video using different candies. And so I might have to update our clinic charts to make this a little bit more fun for our kiddo patients. So she has a Bristol 1 stool. It's hard. Mom has noticed some balls. Mom also has noticed an occasional blood on the toilet paper after wiping. And she has occasional diarrhea. It happens. It doesn't happen every time she stools, but she does notice some leakage, and she's even had some accidents. She was potty trained at 3 years old, and she's been potty trained, but she's still having these occasional accidents now. And the one thing that I always like to ask is if the patient has clogged the toilet. And yes, mom says she's clogged the toilet multiple times. So we know that she has had large volume stools as well. So she's not had any vomiting weight loss, no fevers, no rash, no belly, pain that's not associated with the bowel movements, no abdominal distension. Her diet is very limited, and this is what mom said was the hardest thing to change. So she, for breakfast, has waffles and toast. Lunch is chicken nuggets, pizza, and occasional applesauce, but only from this one specific pouch. And dinner really looks like lunch. So options are very hard to expand the diet for this little one. There's family history. Mom has diabetes, type 2, and dad has hypertension. And so on physical exam, JD looks well, no acute distress. Her ears, lungs, heart, everything is normal. On her abdominal exam, she is tender when we push deeply onto her left lower quadrant. We don't feel any masses. Her bowel sounds are normal. So a digital rectal exam is not always needed in children, especially with behavioral problems. But most of the time they will let you at least look, and that's pretty helpful. Now in adults, this is different. You definitely want to do a digital rectal exam. You need to exclude a mechanical obstruction like a tumor or a mass. You need to assess sphincter tone and if there are any pelvic floor dysfunction. So this is different from pediatrics and adults. And so when this is a picture of what rectum can look like. And so you can sometimes find tears if you have large volume stools that can cause some bleeding, and that's called a fissure. You can also have skin tags, and those are usually seen if you think of this as a clock at 12 o'clock or 6 p.m. And that can be seen in chronic constipation as well. But this patient did not have any of this. She had clear skin, and neurologically she was also normal. And so we, in order to make the diagnosis of constipation, we use what's called the Rome criteria to help us recognize when someone has constipation. So for children and adolescents, you must have more greater than 2 of the following for at least 1 month. So less or equal to 2 stools in the toilet per week. So that's our patient. History of a painful or hard bowel movement. So this is our patient too. History of retentive posturing, and then a history of large diameter stools that can obstruct the toilet. This is our patient. A presence of a large fecal mass in her rectum. We did not look in her rectum, so we're not sure about that. And then greater or equal to 1 episode of fecal incontinence per week, or that leakage or accident. And she's definitely having that too. And insufficient criteria for irritable bowel. All right, so here's a little bit of anatomy around constipation. So the rectum is a storage compartment for the stool, so before it exits through the anus. And so it is like a muscle. With time, it can expand, and you can hold more stool if you don't have regular bowel movements. And so on the right, you can see this is a large, hard stool that can get stuck. And then it can also cause obstruction. So there's stool that is trying to get through that comes around and is a little bit more loose, and it can actually seep around the hard stool, and it can cause accidents, and it might look like diarrhea when in fact you are actually constipated. And so here's a little bit of more background information. 95% of constipation in children is of functional origin, which means it's not associated with a disease like hypothyroidism or celiac disease. 25% of children treated for functional constipation continue to have symptoms into adulthood. So it can be a long run with symptoms. 50% of the children referred to a GI doc are still symptomatic after 5 years. So it can be hard sometimes to treat. And 20% still struggle with symptoms after 10 years. So this is a chronic problem in a lot of children. 75 to 90% of children with chronic constipation seen by a peds GI doctor can suffer from rectal incontinence. So that is that leakage around the ball that can look like diarrhea. And most kids have this withholding behavior. So they're trying to hold their stools in. They don't have time to go to the bathroom. They are busy bees, or sometimes they're scared to use the bathroom. And this is just kind of an endless circle that can get worse. And so here's an overview of a lot of factors that can cause constipation both in children and adults, including lifestyle factors and motility factors. There's this well-known established connection between the brain and the gut. Psychological and behavioral factors such as ADHD or autism can be associated with functional constipation. Same thing with psychological disorders, anxiety and depression, and so many more. All right, so how to approach to manage this kiddo. So do we always need imaging like an x-ray? No, right? An x-ray is just gonna show us that there's stool in the colon, and guess what? That's the job of the colon. We know that there's gonna be poop in the colon. And so we don't have to put this kiddo through an x-ray just to tell her what we already know. Do we need additional labs? Well, like I said, constipation can be associated with things like celiac disease, thyroid disease, lead poisoning, but without other alarm signs, like for example, poor growth in celiac disease, constipation alone would not be something that we would need to explore further testing. So if there's a suspicion with other symptoms, yes, of course. But I don't think that this kiddo would benefit to be put through lab draws, especially if there are any behavioral problems. So the first step that we need to do is clean out those pipes. Sometimes kids need an enema, which is a medicine that goes up the bottom to try to move things along. But what's important is we want to clean out really well. I usually do this over 2 days. We use a stimulant laxative and an osmotic laxative. I'll show you examples of those on the next slide. At kind of higher volumes, kiddos need to be next to a bathroom. They need to be cleaned out well. And then the next day, like on a Monday, we use the 2 different laxatives to make sure that the kiddos are regular and they have daily soft stool. So I always tell them the goal is soft serve ice cream. If your stool is like that, where it's soft, it's easy to push through, you don't see any hard balls or blood, then that is a good management regimen to your medicine. And so I also like to see these kiddos back pretty frequently and talk about different doses over the phone. I'd like them to call me if they have any trouble. That is really, really important for good communication. So here is a quick overview of different types of laxatives we can use. So bulk forming laxatives, we don't use these as much in pediatrics. They add volume to your stool by absorbing water, like Benefiber. This can be over the counter. Osmotic laxatives. So remember, the main goal of a colon is to draw water out so that it makes your stool harder formed, so you can pull it out. So osmotics actually bring more water back into that stool so that your poops are softer and you're not having those hard balls. So things like Miralax, Colace, Milk of Magnesia, and lactulose. And then a stimulant medicine. So these actually irritate and move that colon, those colon muscles, to help you push out the poop. So I like to use both an osmotic and a stimulant laxative for a good regimen so that your stools are soft and you're able to push them out. And examples of the stimulant medicine is Senna, Dulcolax, Bisacodyl. You can also, chocolate X-Lax squares, you can also get these over the counter. So here, I'll leave you with a little quote. So it's a little bit corny, but most of my research that I've done recently has actually revolved around working with stem cells. And I was making mini gut organoids in Petri dishes. And so I can tell you more about those next time, but the bottom line is be like a stem cell and differentiate yourself from others. I'm not actually sure whose quote this is. I tried to look this up and was unsuccessful. So if y'all find it, definitely let me know so I can give this person credit. But make yourself stand out in applications. So either through hobbies or your personal statement, volunteering, whatever it is. I go through many applications during interview season, and I can tell you that the ones that positively stand out, we remember, and we definitely want to meet those folks in the future. So thank you again, web shadowers. I think this is really wonderful what the ladies have put together. This is a picture of a contrast study that is through the colon, and it looks like a question mark. So I thought this was very fitting. One of our colleagues sent this to us not too long ago. And so if you have any further questions about pediatrics or gastroenterology, definitely reach out to me. Send me a message, and then let me know what you'd like to hear about next time. If there are certain diseases you'd like to know more about. I was thinking about talking about IBS versus IBD or celiac disease. So definitely let me know, reach out, and then I can definitely answer some questions now for a few minutes. If y'all sent those to me, let me look here. All right. So one of the questions is, what do you do if the baby is losing weight because of reflux? That is a really, really good question. We sometimes, we have to first figure out if it's because they're not getting enough in or if they're refluxing too much. We like to make the formula bottles, if they're on formula, we like to increase their calories in those specific bottles. And we have frequent visits at this point. We tend not to use medicine like anti-acid suppression medicine in these babies. And if the weight loss is very bad, or if the reflux is very bad, causing a lot of weight loss, sometimes babies need a special tube that goes through their nose and down to their stomach to help them keep some of those calories in. And so that is more of a last resort. We try to make changes to their bottles and to increase their calories by mouth first before getting to that. So another question is, how would autism affect constipation? So the one thing that I sometimes see with autistic patients is that they don't have a very broad diet. And so they're not eating a lot of fruits and vegetables that can help you have more regular bowel movements. They have a very narrow palette of what they're actually taking. And so it's a lot of behavioral things we have to work on. We also sometimes send them for therapy to help expand their palate and be able to provide more nutrients that way. This is another really good question. So is it okay to take an osmotic laxative long-term? I've heard that stimulant laxatives can cause problems if used for too long. So I get this question asked a lot from parents, and there have actually been studies that have shown in pediatrics too, that you can take a stimulant laxative and be successfully weaned off of it once you get the rectum to be at a good size. Remember, so rectum is like a muscle. So if you can't exercise a muscle one time and expect results. So it's a process that can be, ongoing for a few months. And then within a few months, we can try to wean off of the laxative, and it's usually pretty successful, but it also depends on the patient's age. So kiddos are just busy bees. Sometimes we might have to wait longer to wean them off of their medicine until they realize that they have to make time to use the bathroom. They have to eat a certain diet. They have to do these other things that can help them as well. So that was a really good question. What does a typical work day look like for you? So I have a pretty fun week schedule. I see patients in the clinic 3 days of the week. And then the other day I have a day of procedures. So I'm in the hospital doing my scopes. And that includes upper scopes and lower scopes as well. And then I have 2 days for research. So I'm really interested in quality improvement. And so I'm working with folks on bettering quality improvement for inflammatory bowel disease. So I do that for a day of the week. And then we also have, because I'm in an academic center, we do conferences. So we get together with all of the pediatric GI docs and the division as a whole. And we have lectures every week. And so that really keeps us all updated. We work with fellows and residents, so we have them present as well. So the week is really quite fun. I love that I can do clinic and procedures and education on the regular, and so that's really awesome. This is a little bit of a bigger question, which I don't know if I'll be able to answer all of. What do you do with a teenage patient who does have psychological disorders affecting their gastrointestinal issues? And so we work really closely we have specific GI psychologists in our practice, and they help us a lot with this. There's only so much time that we can spend also in clinic. And so these patients definitely need a lot more time to talk about everything. And they are absolute amazing with this. And then, if things get bad or we can't manage on an outpatient service, then we have to think about admitting patients if they need to, if they're having problems with weight gain or anorexia or anything like that. Did you have to reevaluate your credentials from Poland to the United States? So no, I went to Poznan University of Medical Sciences. It was an English-based program. And so all of our exams the NBMEs we had were in English, and they translated to the US standards. And then I did my board exam, like step 1 and step 2 in the States here, just on the same track as you would at a medical school in the United States. How do you balance dealing with both your patient and their parents? So the patient, it depends on their age. Usually the kiddos are running around in the clinic room. Sometimes parents will give them an iPad. Sometimes we'll blow up a rubber glove and make it a balloon to entertain them. It's, if they're young, that's what we have to do. And a lot of the time is just spent talking to the parents. But if they are older, I definitely want to hear from the patient. I ask the patient direct questions. I want them to be as involved in the clinic visit as their parents are, if not more, because they are really at this point understanding what is going on, and they're going to be helping with management, especially if they need to be taking a medicine. They need to remember to take it. They need to put an alarm on their phone. They have to work with me as much as the parent does too. Okay, so this is the last question. What are the strongest qualities you see in successful applicants for medical school? So I think oftentimes, there is when we get applications, when med schools get applications, they have kind of a sorting thing. So they will take scores that are above X or Y. And then when you pass that, then they look into things like your personal statement, your extracurricular activities, your hobbies, your volunteering. I think that the best way to shine is through a personal statement. I think that is where you can write, you can make it interesting, you can really stand out. I think taking time to write that is going to go a very, very long way. And so I'd really, really encourage you to really take time with that. Okay, this is the last question. Are DOs as likely to get into GI residencies as MDs? So yes, MDs and DOs, we have DOs in our program. They work with us. We are colleagues. I think that it's once you are in residency, so pediatric residency, you have to do first, and that then getting into GI fellowship is the same for both. So yes, I would definitely say that. All right. Message me if you have any further questions. Next time we'll talk about some of the other diseases that I see in clinic. And if you're interested in anything, definitely let me know.
Thank you so much, Dr. Schirtz. This was a wonderful presentation and very interesting to learn. We all appreciate you so much. Everyone, make sure you check her out on her socials. Her Instagram is @gastrodoc.md.
Hey, web shadowers, before we close out today's session, Isis and I just wanted to come on the call and briefly make an announcement to all of you.
So as some of you may have seen on our Instagram story, we are now introducing monthly roundups.
Our consistent format of requiring live attendance will stay the same, and our Google form will still continue to stop accepting responses after 30 minutes.
Yeah, we've had some confusions about whether we're changing the format of our live streams or not. The only difference from here on out is that on the last weekend of each month, we'll be opening up the forms to allow all of you to go back and watch the recordings of the live streams that you were not able to attend if you choose.
Our first roundup will be taking place this coming weekend. Friday, October 2nd at 11:59 p.m., the forms will start accepting responses again. And on Sunday, October 4th at 11:59 p.m., they will close. And this is at EST, by the way.
You will be able to watch any session from the month of September, including our August 31st session, and fill out the form and receive credit. But please keep in mind that these summaries should be at least 10 sentences.
We will keep posting about the roundup to remind you all about it until it happens. We hope it'll be beneficial and that you'll be able to earn the hours that you'll need for your cumulative certificate at the end of the semester, which will be announced next weekend. Additionally, thank you all for attending, and thank you again, Dr. Schirtz. The link to the Google form has been posted in the comments, and it's also in our Instagram bio. So please remember, you need to fill it out within the next 30 minutes for us to receive your verification.
Thank you so much, Dr. Schirtz.
Thanks, y'all. Have a good rest.